It is 2 in the morning. You have been off your feet for hours and the sole of your foot is on fire. Not sore, burning, a hot electric band from the inside of your ankle into the arch and toes. It builds all day, and at night it wakes you. You have been told it is plantar fasciitis. You have had the heel injections, the night splint, the new shoes. None lasted. I am an interventional pain physician in St. Louis. I run the Padda Institute Center for Interventional Pain Management, and I want to be precise about what failed you here, because it was not the injection. It was the sentence that came before the injection. Plantar fasciitis hurts at the heel, worst in the first steps out of bed. Burning across the whole sole that worsens the longer you stand is a nerve talking. A third heel injection is not new evidence. It is the same missing diagnosis, repeated. Behind that bump on the inside of your ankle is a tunnel. Its floor is bone, the medial malleolus of the tibia above, then the medial wall of the talus, then the calcaneus. Its roof is the flexor retinaculum, a tough, fibrous band. Through it run 3 flexor tendons, the posterior tibial artery and veins, and the posterior tibial nerve. Past the tunnel, it divides into the medial and lateral plantar nerves which supply the sole. But the medial calcaneal branches usually leave above the retinaculum, which is why the heel is often the one part of the foot that feels normal while the sole burns. And almost nobody looks. Anything filling a compartment that cannot enlarge raises the pressure inside it. Tenosynovitis of those tendons, varicose veins, a ganglion cyst off the subtalar joint, hindfoot valgus, where the heel drifts outward and keeps the retinaculum under tension. Be careful with the mechanism as it is taught. It outruns the human evidence. Raised pressure is thought to throttle blood flow in the epineurium, the nerve's vascular sheath. Myelin is lost focally, conduction slows, and sustained axons die. That sequence comes from animal compression models, not from human tarsal tunnels. It may explain the timing. Standing loads the tunnel, so pain builds through the day, and at night, venous congestion keeps the nerve irritated, but night pain is not a signature. Diabetic polyneuropathy is at its worst at night too, and it is far more common. Night pain tells you the problem is neural, not where it is. An S1 radiculopathy burns down the calf into the sole. Diabetic polyneuropathy burns in both feet, symmetric, in a stocking pattern. Morton neuroma sits between the metatarsal heads. Complex regional pain syndrome adds color and temperature change, swelling, allodynia. And these coexist. A nerve stressed by metabolic disease may tolerate compression poorly, so polyneuropathy does not rule out an entrapment on top of it. That double crush idea has more plausibility than proof. I use it to stay open-minded, not to justify a needle. Which means the first orders here are not imaging. Fasting glucose and hemoglobin A1C, B12, with methylmalonic acid if it is borderline. Thyroid function, where the history warrants it, kidney function, and an honest accounting of alcohol. A metabolic neuropathy nobody has diagnosed is not fixed by a needle at your ankle. In the room, examination comes first, whether percussion behind the medial malleolus reproduces your exact pain, and whether the deficit follows a plantar nerve, a nerve root, or neither. That sign turns up in people with no entrapment and in generalized neuropathy. It opens the argument, it does not close it. Then electrodiagnostics. An evidence-based review by Patel and colleagues in Muscle Nerve in 2005 concluded that nerve conduction studies may be useful for confirming tibial neuropathy at the ankle E, at recommendation level C, the weakest useful grade, and that sensitivity and specificity could not be determined. A normal study does not exclude tarsal tunnel syndrome. If you were told otherwise, you were misinformed. Ultrasound adds what electrodiagnostics cannot: the cyst, the tendon sheath, the varicosities, the swollen nerve above a narrowing, live with the ankle moving. It is operator dependent with no established sensitivity here. Where the question is a mass, marrow, or dense scar, MRI answers better. Where hindfoot alignment is the driver, weight-bearing radiographs answer it and ultrasound cannot. Then a diagnostic tibial nerve block, which helps localize the pain generator. It is not validated as confirmatory, no response threshold proves the diagnosis, and an uncontrolled block carries a real false positive rate. One input, not a verdict. When history, examination, imaging, and block converge on the same nerve in the same tunnel, and when orthotics, activity modification, and a real course of physical therapy have already failed, then we treat it. Not before. Nothing that follows belongs at a first visit. One decision comes first. If ultrasound or MRI shows something occupying the tunnel, a ganglion, a mass, gross varicosities, dense scar, the definitive treatment is surgical excision and decompression, not an injection. I will say so and send you. Hydrodissection is for the tunnel that is tight with no lesion to cut out, or for the person who cannot have surgery. Anyone offering a needle before answering that question has skipped the one that matters. Hydrodissection is the first interventional step. With a high-frequency linear transducer, I find the nerve in short axis, sitting against the artery and veins. The needle goes in plane under continuous vision, and fluid is delivered between the nerve and the structure compressing it. The mechanism, lysing adhesions, diluting inflammatory mediators, is inferred from cadaveric and animal work, not shown in living humans, and the strongest evidence for it is not in the foot. Wu and colleagues in Muscle Nerve in 2019 randomized 34 patients with mild to moderate carpal tunnel syndrome to paraneural saline hydrodissection or a control injection, double-blind. 34 symptom scores beat the control at 2 and 3 months, and only at 2 and 3 months. Nerve cross-sectional area stayed smaller out to 6, but the relief did not last, and that is the wrist, not the foot. In the tarsal tunnel, published experience is case series. There is no controlled trial. The procedure is off-label whatever the injectate. Saline, 5% dextrose, corticosteroid. Know that before you consent. The nerve lies against the posterior tibial artery and vein, so bleeding, intravascular injection, and hematoma inside a closed tunnel are real. Infection, intraneural injury leaving new burning or numbness. Your soul is numb for hours. Do not drive until sensation returns, and protect that foot from heat and pressure, especially with neuropathy. Corticosteroid raises blood sugar for days. Peripheral nerve stimulation is not a foot treatment. It is last line for confirmed, refractory, well-localized neuropathic pain after image-guided care has failed. A systematic review by Char and colleagues in Biomedicines in 2022 graded that evidence very low to low quality, with no study addressing tarsal tunnel syndrome. Leads migrate, skin erodes, infection can force removal, and there are MRI restrictions. What I am about to describe is a composite, a picture assembled from many patients with this condition. Not one person's chart. An adult on their feet all day. 2 years of burning in the soul, worse by evening, waking them before dawn. 3 heel injections, orthotics, physical therapy aimed at the fascia. A normal nerve conduction study which they were told closed the question. Percussion behind the inner ankle bone reproduced the exact pain, suggestive, not decisive. And the deficit followed a plantar nerve, not a nerve root. Ultrasound showed a distended tendon sheath narrowing the tunnel and no mass that needed cutting out. A block dropped the burning for the duration of the anesthetic. Supportive, not proof. Hydrodissection changed almost nothing in the first weeks. They were told to expect that. The shift came slowly. Clearer by the 2nd month, clearer again by the 3rd, the interval at which the wrist trial separated from its control. Not immediate and not complete. The first orthotic failed and had to be remade. Near 5 months the burning began to return, and a second hydrodissection was performed, with the understanding stated in advance that this is control measured in months. If burning in your soul has outlasted every treatment aimed at your heel, the right nerve may never have been named. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Start at painem.tv, under foot pain. Ask which nerve. Ask to see it on the ultrasound screen before anything goes into your foot. If nobody can point to it, nobody has earned the needle. If something in this changed how you understand your own pain, that was the point. Bring us your imaging, your history, and your questions. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Everything in this video is education, not medical advice. Ask for the diagnosis before you accept the procedure.